Acromegaly. Acromegaly is the clinical disorder resulting from hypersecretion of growth hormone, GH. Etiology and pathophysiology. The majority of cases are caused by a pituitary adenoma. Of these, 70 to 75% are macroadenomas, greater than 1 cm in diameter, and 25 to 30% are microadenomas, less than 1 cm in diameter. A small number of cases have been reported in which acromegaly results from ectopic growth hormone releasing hormone, GHRH, secretion. Many of the growth-related aspects of this disorder are mediated by insulin-like growth factor, IGF-1, which is produced by the liver in response to GH, whilst GH itself has direct metabolic effects, e.g. induction of insulin resistance. Epidemiology. The incidence of acromegaly is estimated at approximately 3 to 5 per million per year, with a prevalence of 40 to 70 per million. Patients are typically diagnosed in early middle age, although the onset of disease, and hence symptoms, often predates the diagnosis by 5 to 15 years. Clinical presentation. The diagnosis of acromegaly is often first raised by a clinician, dentist, or optometrist, who encourages the patient to seek advice for changes that they had attributed to aging. Commonly reported symptoms include an increase in the size of the hands and feet, often noted as changes in ring and shoe size respectively. Coarsened facial features, altered bite and prominence of the jaw, prognatism. Features of carpal tunnel syndrome. Snoring, reflecting sleep apnea, which may be central or obstructive in etiology. Arthralgia. Sweating or oily skin. Thirst and polyuria, diabetes mellitus. Local symptoms due to the space-occupying effects of a pituitary tumor, e.g. headache and visual disturbance. Amenorrhea, loss of libido or erectile dysfunction secondary to hypogonadotrophic hypogonadism. Tubulovillous adenoma and colonic carcinoma, also thyroid nodule, including malignant, are recognized to be more common in patients with long-standing acromegaly. Physical signs. Many of the symptoms reported by the patient correlate with specific signs on examination, including evidence of large spade-like hands and feet, prognatism, and coarsened facial features. Hypertension is a common finding, and long-standing untreated disease may lead to concentric myocardial hypertrophy and ultimately cardiac failure. NB. Careful examination of the visual field is essential to check for evidence of bitemporal quadrantanopia or hemianopia. Investigation. Biochemical confirmation of the diagnosis is usually made using an oral glucose tolerance test in which GH levels show a paradoxical rise or failure to suppress in response to a glucose challenge. In addition, the IGF-1 concentration is typically elevated above the age-related normal range. Once the diagnosis has been established, imaging of the pituitary fossa should be carried out, preferably by MRI, and visual acuity and visual fields formally assessed. A full appraisal of anterior pituitary function is also necessary. Remember that 20–25% of GH-producing tumors also secrete prolactin. Treatment. NB. The goals of treatment in acromegaly are to effect a cure, preserve/restore remaining pituitary function, and reverse/control complications. Evidence suggests that even if a cure cannot be achieved, then providing that the mean GH level throughout the day can be reduced to 5 μ/L, the life expectancy of patients with acromegaly approximates that of the general population. Surgery. The first-line treatment for acromegaly is usually surgery. In experienced hands, transsphenoidal adenomectomy offers a surgical cure rate of approximately 80% for microadenomas, although this drops to less than 50% for macroadenomas. Recurrence rates are estimated at 2 to 7% over 5 years in patients originally considered to be cured postoperatively. Radiotherapy. Radiotherapy may be given if there is residual tumor postoperatively with persistent elevation of GH or if the patient is medically unfit for surgery. Note that although beneficial effects of radiotherapy are usually evident within 12 to 24 months of treatment, it can take much longer for GH to fall to safe levels. Approximately 50% of patients achieve adequate suppression at 10 years. A similar proportion of patients at the same time point have hypopituitarism involving one or more trophic axes. Stereotactic radiosurgery, in which the total treatment dose is administered in a single or small number of fractions, may be an option in some patients, e.g. when the residual tumor is not in close proximity to the optic chiasm, and can lead to more rapid control of GHCS excess. Medical therapy. The role of medical therapy in the management of acromegaly is evolving. Traditionally it has been used to supplement surgical treatment, as a holding exercise in patients who have had radiotherapy, or as first-line treatment in patients who are unfit for surgery. Somatostatin analogues, somatostatin receptor ligands. First-generation somatostatin analogues octreotide/lanreotide and their longer-acting preparations, improve symptoms in most patients and achieve good biochemical and tumor control, especially when used as an adjunct following incomplete surgical resection. Gastrointestinal side effects, including nausea and diarrhea in the acute phase and an increased tendency to gallstone formation in the longer term, are relatively common. The second-generation somatostatin receptor ligand pasireotide has recently been introduced and appears to offer greater efficacy, especially in patients whose condition is refractory to octreotide and lanreotide. However, it predisposes to hyperglycemia, with many treated patients requiring commencement or escalation of anti-hyperglycemic therapy. Dopamine agonists. Dopamine agonists, e.g. bromocriptine, cabergoline, only suppress GH levels to acceptable safe levels in less than 15% of patients, although they may be useful if the tumor CO secretes prolactin, or when combined with a somatostatin analog. Growth hormone receptor antagonists. Pegvisomant, a growth hormone receptor antagonist, lowers circulating IGF-1 levels into the normal range in greater than 90% of patients, thereby improving many of the clinical features of acromegaly. However, it does not reduce pituitary tumor size nor lower GH secretion, and indeed during treatment GH levels can rise by up to 70% over baseline, which is probably caused by a loss of negative feedback due to the reduction in IGF-1. The drug is also expensive, and is given by daily subcutaneous injection. Currently, its use is limited to those patients who still have uncontrolled disease despite surgery, radiotherapy, and somatostatin analog therapy. Liver function tests must be monitored during treatment and MRI repeated at 6 monthly intervals or sooner if there are any concerns regarding tumor growth. Other risk factors. NB. Aggressive treatment of other risk factors is essential, including hypertension, diabetes mellitus, dyslipidemia and sleep apnea. Most centers also offer screening colonoscopy once the patient is of an appropriate age, as available evidence suggests that the risk of colon cancer in acromegalic subjects is about twice that of the general population. Those with a family history of colon cancer are likely to be at particular risk. A holistic approach. Other causes of morbidity should not be overlooked, with patients frequently requiring rheumatological or orthopedic assessments, dental or maxillofacial opinions and psychological input or support to address problems of body image. Follow-up. Following treatment, periodic MRI scans are required, together with assessment of visual fields, the GH-IGF-1 axis, and anterior pituitary function. Prognosis. The mortality of subjects with acromegaly has been estimated to be 1.5 to 4 times that of the general population, mainly due to an excess of cardiovascular, cerebrovascular, and respiratory disease. Remember that the mortality rate approaches that of the general population if mean post-treatment GH levels are less than 1 microgram/L and IGF-1 is normalized. Disease associations. Acromegaly may be associated with parathyroid and pancreatic tumors as part of multiple endocrine neoplasia type 1 syndrome, or with cutaneous and cardiac myxomas, primary pigmented nodular adrenal disease and testicular tumors in the Carney complex.